Hi, it's Matthew Links. Welcome to this third part in the series of BSOC Lung 2014, Applying Targeted Therapies to Special Populations. So in the first two sessions we went over molecular pathology and then the general evidence that supports the use of targeted therapies. But many of the patients that we see are in so-called special populations where the evidence for targeted therapy may need modification. So the understanding today that we'd like to achieve is that many cancer treatments decisions apply to patients in special populations, to be able to identify these and to understand the literature regarding targeted therapies for these populations. So if we go over briefly how we make an evidence-based recommendation, then randomised trials, meta-analyses, etc. define the standard of care. But there are modifying patient factors from individual patients that affect the decision, and the patient's wishes also need to be taken into consideration. And this category of special populations are factors that modify recommendations from standard phase 3 trials. Now, targeted therapies are particularly interesting for this because they have generally a more favourable therapeutic index. And this means that the rules in these populations may not be the same rules that we use for lung cancer more generally. So we need to consider what the rules should be. Now, the first thing to understand is that most patients are special. This is a beautiful study by Jeanette Vardy and Stephen Clark and colleagues. They looked at their centre how many patients actually fitted the criteria for clinical trials. And you can see that there are only a quarter of patients that fitted the criteria and would therefore fit the population that the treatment was given in. Vast majority of patients would have been excluded because of some special population type consideration. Now, the most obvious one is the age. And this is our data for lung cancer patients, and most of our patients are over 70. So clearly this is not a minor population. This special population is in fact the majority of patients that we see. If you look at drug interactions, this beautiful study of 400 patients from Ambulatory Cancer Centre, and a quarter of patients were on drugs that cause significant drug interactions. Again, not a minor problem. Coming to renal impairment, there is a large French population study called IRMA, which looked at over 4,000 patients. And although the incidence of elevated creatinine was relatively low at 7.2%, 50% had an abnormal GFR, and 50% of prescriptions required some sort of adjustment. And 80% of patients received nephrotoxic drugs in their treatment. So this issue of renal impairment is really a major one. So what do we do with these special populations? Well, there's two things. First, you can act from general principles, but preferably there may be specific data to speak to this problem. So let's look at the elderly. What are the general principles? Well, we try and stratify people into frail, intermediate or fit. Treat fit patients with standard therapy, frail with supportive care, and look at some sort of adjusted therapy in the intermediate patients. So do these rules apply for targeted therapy? Then there's two types of specific data. There is the subgroup of elderly in clinical trials. This really only refers to the fit elderly. And then there are specific trials done in the elderly. Well, let's look at EGFR inhibitors in the elderly then. This is a study that looked at a subgroup from BR21, the placebo-controlled trial of erlotinib, in patients greater than 70. And you can see that compared to those under 70, the efficacy was about the same, but there was a significant increase in grade 3-4 toxicity, patients stopping treatment because of toxicity, and a reduction in dose intensity. These levels are probably acceptable, but are giving us a strong signal that toxicity is increased in the elderly. What about the poor performance status? Well, here chemotherapy rules are generally that we treat patients 0 to 1, ECOG 3 patients we don't treat, and ECOG 2 patients need some caution and treatment with a well-tolerated regimen. So do these rules apply? Well, there is a specific study called Topical, which looked at EGFR inhibitors in poor performance status patients. They were molecularly unselected, reasonably large number, 670. They were mostly ECOG 2 with multiple comorbidities, but a third were ECOG 3. And the message from this trial is that toxicity was manageable, but survival was quite short. And if you look specifically at the EGFR mutated patients, which were only seen in 7%, then the median survival was around 10 months compared to 3.7 months in the placebo group. So quite a significant increase in survival for these patients. For organ dysfunction, the general principles are about understanding the pharmacokinetics, particularly the routes of metabolism. You have to be careful about, say, renally excreted metabolites. And you also need to consider pharmacodynamics. So a hepatically excreted drug that causes diarrhea can be a problem in someone who's got renal failure. And then there's specific data, clinical trials that are specifically designed for patients with renal hepatic dysfunction. So for erlotinib, there is such a trial. It's done by the CLBG, who have a group that is devoted to answering these sorts of questions. And it's generated some recommendations. No dose reduction for renal impairment, but a reduced dose for hepatic dysfunction. But if you look at the study, it's relatively small, 55 patients with hepatic and renal dysfunction, which leaves only 18 with renal dysfunction. There was dose escalation, so less patients got the full dose. The number of patients with renal insufficiency treated at full dose is 18. And the elevation in creatinine overall wasn't all that high. So that when it comes to patients with severely impaired renal dysfunction, the number of patients that this guideline is based on is really pretty small, and some caution's required. For drug interactions, this is a major problem for both EGFR inhibitors and crizotinib. So in EGFR inhibitors, there are recommendations that people who have toxicity on a CYP3A4 inhibitor have a reduced dose, and special caution is needed with combined CYP3A4 and CYP1A2 inhibitors, and these should be avoided where possible. The most difficult recommendation is to avoid proton pump inhibitors because many patients are on these. And this is both from an acid suppression point of view as well as from a CYP3A4 point of view. Crizotinib is an even more dangerous problem because the toxicity of concern is prolongation of QT interval and sudden death. So drugs that also increase the QT interval are a problem. And you can see, looking at the list of drug interactions with crizotinib, it's really very large, and some of these are the commonly used drugs. So the message is that we need to think about these. We need to know what medications, non-cancer medications, our patients are taking, and we need to be hyper alert for these as possible effects. Okay, what about people who present with oligometastatic disease? This is an important group in targeted therapy, as we do see people with oligometastatic disease suitable for targeted therapy where we need to make decisions about local treatment. We also see people who have progression of oligometastatic disease on an EGFR inhibitor where there's an option of local therapy. So what are the first principles? Well, the patients with oligometastatic disease tend to do better. There is this potential role for local therapy, but evaluation of the data is difficult because of selection bias. Resistance, though, targeted therapies is universal, so it's quite appealing to be able to deal with localised disease, and there's the potential for extending the duration of response and also cost. And then there's potential for specific data. Now, there's not a lot of this, but if we look at it in terms of general principles, there is supportive evidence for treatment of oligometastatic disease. This study looked at the benefit of a radical approach to local treatment for oligometastases, showing in an unrandomised fashion a tend to increase survival for higher doses of radiation. And there's some specific data. This is a study that used local ablative therapy for patients with oligoprogressive disease, and that was able to prolong the disease control by the tyrosine kinase inhibitor for about 6 months. So there is data to support this sort of approach. Similarly, CNS metastases, they're all different sorts of brain metastases, and really it's competing risk of systemic disease that affects priority given to the brain. But we need to remember that delaying systemic therapy for CNS therapy can result in death, and vice versa, and that the blood-brain barrier is compromised by the tumour. And there is some specific data. So the role of ilotinib in EGFR mutated CNS tumours is approximately 82% response rate with an overall survival of around 13 months, which is pretty good for brain metastases and a comparable response rate to radiation. But at the same time, there's this contrasting theme in the literature of isolated CNS relapse in patients whose blood-brain barrier is intact, who have developed resistance to EGFR inhibitors. And this study has used high-dose pulsatile ilotinib with CSF concentration measurement to demonstrate that you can increase the concentration in the CNS. And for watch this space, there are potential genetic variabilities to modify the response to EGFR inhibitors, including metabolism, genes that modify the response and modify the target, such as SNPs in EGFR. So this is an area that I think will evolve. So in conclusion, there is specific literature to guide decisions on special populations. The data varies from context to context, and there are often gaps where the best evidence is from general principles, and you really need to know this data and apply it in order to make good decisions. Thank you for your attention.